All right, so people can hear us now. Hello, this is Dr. Schäfer from Heidelberg, Germany. Welcome to the webinar on tuberous sclerosis complex. This will be given by Dr. Rosa Torra from the Fundacio Puigvert in Barcelona. Dr. Torra is a very outstanding and renowned nephrologist with a strong interest in ADPKD and tuberous sclerosis. She runs one of the largest clinics, probably the largest in Spain and one of the largest in Europe for this rare disorder. And we are looking forward to her presentation on what's new in TSC. Rosa, please take over.
Thank you, Franz, for your kind introduction, and thank you to ERKNet for inviting me to give this talk. I will share with you some experience on tuberous sclerosis. Some basics on tuberous sclerosis. It is a rare autosomal dominant genetic disease, one in about 8,000, sorry, there's a zero missing there, characterized by development of benign tumors and lesions in various organs. It is caused by mutations in the genes TSC1 or TSC2, which code for hamartine and tuberin respectively. They both form a complex that indirectly inhibits the activity of the mechanistic target of rapamycin. So we have two genes here, likewise in ADPKD. Here we have TSC1 and TSC2. They're both large genes with several exons, and TSC2 is larger and is more frequent. It accounts for almost 80% of cases of tuberous sclerosis. This disease has a very high penetrance as polycystic kidney disease, similar, around 100% penetrance on age, and many mutations have been described. Most of them are single base substitutions, but a significant number are large rearrangements. In 10 to 15% of cases, we identify no mutation. These are the no mutation identified cases. And importantly, 2/3 of cases are de novo mutations, which means that neither father nor mother have the disease. It's a de novo mutation. And regarding genotype-phenotype correlation, it is well known that TSC2 is usually more severe than TSC1, and that some missense mutations in TSC2 have a very mild phenotype. But the most outstanding phenotype is that the one caused by the contiguous gene syndrome that we will see with deletion of these two genes that are very, very close, PKD1 and TSC2. So we mentioned that 70 to 90% have identified mutations, but otherwise it is called no mutation identified. What's the cause of not finding a mutation in a genetic disease or specifically in TSC? Well, this mutation can be in non-coding regions, or mostly it's mosaicism, which means that the patient has the mutation in very few cells. So in a regular sequencing of that patient, we do not pick up the mutation. So generally, TSC1 and TSC2 mutation result in premature termination of translation. And as I mentioned, yeah, they're usually small base substitutions. Nowadays, the diagnosis is mostly performed by next generation sequencing. The advantages are very clear. They are both large genes, as I mentioned. The cost is lower, it's quicker, and mosaicism can be detected if you have high coverage and you have enough reads. But the drawbacks is sometimes it's not that easy to detect large in and del, in insertions, deletions. There's a high number of variants per individual, then you need to filter to prioritize. There's not an available functional test. So as you know, for those using next generation sequencing, it usually, it may be quite tough to classify variants. Some studies can be done with RNA based, but it's not a clinical practice, a regular clinical practice, I would say. Mosaics, although they should be easier to pick up with next generation sequencing, still they may be missed in regions with low coverage of reads. And well, this is a very practical issue that sometimes you need to have a large number of individuals, depending on the number of diseases that you cover in the panel that you're using, or well, technical things. So what's the molecular pathology behind TSC? Loss of heterozygosity, as described by Knudson for retinoblastoma many years ago, consists of the patient has a germline mutation, and then a second mutation, a somatic mutation appears, and it behaves like a recessive disease with both copies mutated. Also, it can be something like it's supposed to be in PKD with haploinsufficiency. One of the two copies has a mutation, and then the dose of protein is lower than needed. In any case, hamartin or tuberin, this complex does not work properly, and mTOR is upregulated. Well, TSC is a systemic disease, is the paradigm of a systemic disease. We can go quickly through these criteria, and you will see how systemic it is. Hypomelanotic macules, angiofibromas here, angle fibromas in the nails, shagreen patch anywhere in the back, and multiple retinal hamartomas in the eyes, cortical dysplasias in brain, subependymal giant cell astrocytoma in brain, cardiac rhabdomyoma, lymphangioliomatosis in the lungs, and angiomyolipoma in the kidneys. And then the minor fetus confetti skin lesions, dental enamel pits, intraoral fibromas, retinal achromic patch, multiple renal cysts, and non-renal hamartomas. So as you can see, the skin plays an important role to diagnose the disease, not in the severity, of course. And the clinical presentation changes over time. The most earlier presentation, when present, is rhabdomyoma, which disappears spontaneously. And then the neurological features are the worst in pediatric age, and then in adulthood it's mainly the kidney, the big burden of the disease. It's very curious that this disease, I would say, is very neurological in the pediatric age and very renal in adults. And you would say, why? Because they keep having seizures, mental retardation. Yes, but in clinical practice, when they reach adulthood, they've done whatever has been possible to control this epilepsy and mental retardation. So it's then the renal problems start to appear, and the neurological ones remain very stable. So there's usually a change of follow-up for these patients. Well, here we have the pictures of these clinical features, but we will focus on the renal ones. We have three kinds of renal involvement in TSC. Cyst, opposite to other very well-known inherited kidney diseases such as polycystic kidney disease, autosomal recessive nephronophthisis. In this case, cysts have almost no clinical repercussion except for the contiguous gene syndrome that we will go through in a minute. They're more frequent with TSC2 mutations, but as I mentioned, it's not a big issue. Angiomyolipomas are the strongest point and the big problem in TSC in adulthood mostly. And they are more frequent and more severe in TSC2, and they have clinical repercussion. Renal cancer is infrequent, difficult to diagnose, and we will see that in a minute also. Cysts in TSC. 3 different types of cysts may occur in TSC. Glomerular cystic kidney disease has been shown to be present in TSC, but we don't know the real prevalence because it's not easy to diagnose, as you know. It's using renal biopsy, which is not done on a routine basis. Then we have simple cysts, which is very frequent, but it's nothing serious and nothing that you have to worry about. And then we have this infrequent but very important disease. I would say disease is TSC, it's TSC, but it's still a very different disease. because, as I mentioned, these two genes, TSC2 and PKD1, lie together in chromosome 16, very close, even overlapping. And when this region, including both genes, is deleted, then you have, let's say, a different disease. And the patients have a TSC, regular TSC, but they have very severe and very early onset PKD. You can see these enormous kidneys at birth. So these children have significant and chronic kidney disease in the teenage years. And this specific disease, it's between 2 and 5% of all TSC patients. Then we will focus now on AMLs in patients with TSC. AML represent 1 to 2% of all renal tumors. 0.13% of population have AMLs, but only 20% of those have TSC. Then AMLs develop in up to 80% of patients with TSC, but that figure changes according to age. So it's strange to have an older patient with TSC without AMLs, and it's very frequent to have a child without AMLs. So AMLs and TSC are multiple and bilateral renal tumors. The median age of detection, which may mean that they are very, very small, it's 8.6 years. So starting in childhood, but giving problems usually in adulthood. The definition of these tumors is that they are benign hematomas, rich in fat, blood vessels, and smooth muscle, as you can see here. They may occur also in other organs. For example, it's very frequent to have them in the liver also. Recently, it has been reported a parasite origin of TSC-associated AMLs. These parasites are mesenchymal perivascular cells attached to the abdominal surface of capillaries. They have specific functions in regulating microvascular stability, development, and function. And AMLs, like parasites, they express the same markers and accumulate lipid as seen in AMLs. And this is a very interesting recent report by Siroki and collaborators, where they see that TSC-associated AMLs express angiogenic markers and also in the serum. And interestingly, patients with discontinuous gene syndrome, so mainly children treated with ACE or ARBs due to high blood pressure, secondary to PKD, polycystic kidney disease in these patients, those that have been treated with RAS inhibitor have less burden of AMLs. So suggesting a role for a parasite and inhibition of parasites due to RAS inhibition. Well, the size of AMLs increases along age, as you can see here, but as you see, some patients in quite early ages in childhood, they already have large AMLs. Here, specifically in young adulthood, you can see some patients with extremely large kidneys and large AMLs. And this is the rate of growth of AMLs, which is outstanding in early adulthood. What's the clinical presentation of AMLs? They're often discovered as an incidental finding on radiological studies in a TSC patient, but sometimes they rupture and there's an acute bleeding with the classic triad of flank pain, palpable mass, and hematuria. Hematuria may not be present because if it's not communicated with urinary tract, then you don't see any hematuria. But this patient usually go into the casualty department because acute abdominal pain, hypotension, nausea, fever, shock, palpable abdominal mass, sometimes severe acute anemia, renal failure may be also present. So it's quite a catastrophic presentation. And the cumulative risk of hemorrhage in these patients is 18% for women and 8% for men. These AMLs have a kind of hormone relationship with pregnancy and estrogens causing an increase in these AMLs. So what has been done for many, many years? Nephrectomy, embolization. So we find that nowadays 25 to 50% of adults with TSC have an embolization of a nephrectomy or partial nephrectomy. And bear in mind that embolization is not a cure sometimes, because reembolization is needed in up to 45% of patients. And also, very important, keep in mind that the risk of hemorrhage depends on the size of AML, being higher and significantly higher when the diameter of the AML is over 3 centimeters. And there is a phenomenon that I like this word, encroachment of AML's normal tissue that may lead to renal failure. We'll see what's encroachment. Well, this is encroachment, the practically substitution of the renal parenchyma by AMLs. It's not just a tumor, a round one that you can measure, but it's complete replacement, infiltration of the renal tissue by AML. What about renal cell carcinoma? There's a bit of confusion there because it's been said that TSC patients are not a higher risk, but they develop it earlier and different histological types. But some authors say that they are at increased risk, which makes sense because there is a high proliferation rate in these patients due to the activation of mTOR. While it's estimated to be between 1 and 3%, the histology is quite varied, usually low grade. This is important. The disease develops as the cancer appears earlier in age, much earlier than in not-TSC population, so 30 versus 50 to 60, primarily in women. And there especially, this is a very common phenomenon, not cancer, but fat-poor AMLs, sometimes very difficult to distinguish in MRI scan, even CT scan. Experienced radiologist is needed, and sometimes the tumor biopsy is also needed. In fact, in the ERKNet, we had recently a consultation regarding this type of lesions. And what about end-stage kidney disease, renal failure in patients with TSC? As I mentioned, it's common in kids with the contiguous gene syndrome, but what about adults? Well, there are some series showing that around, in this series, for example, 7.3% of patients with TSC reached end-stage renal disease. This is another very large series with a very particular ascertainment, which is a little bit confusing, but anyway, a significant number of patients with TSC reach chronic kidney disease. These are historical cohorts. Hopefully, these cohorts in some years won't have this problem because of the treatment that we will go through. And this is very interesting. In the first slope, you can see that TSC patients have high incidence of chronic kidney disease at their 40s, while it's very different from the UK general population. And here I would like to highlight these children with renal failure because they have this contiguous gene syndrome. So what is the cause of chronic kidney disease in patients with TSC? First of all, this contiguous gene syndrome causing severe autosomal dominant polycystic kidney disease, presenting much more severely than usual PKD, reaching end-stage renal disease in the second or third decade of life. Then we have the loss of renal parenchyma due to embolizations or nephrectomies, which is what we need to avoid in these patients. Then we have the encroachment of renal parenchyma by AMLs, this infiltration replacement of renal parenchyma. Then we have glomerulocystic kidney disease, not sure about what percentage of chronic kidney failure may be caused by this entity. And what's behind that? We have also these somatic second hit mutations occurring during rapid cell division when the skin is still growing, has a potential repair capacity, and that may cause an accelerated loss of normal renal tissue. This is a hypothesis. I would say that the first three are real for sure, and then we have this hypothesis, second hit, causing loss of normal renal tissue leading to CKD. Then we also have the hypothesis of haploinsufficiency that may lead to a modest mTOR overactivity, and this may cause glomerular hypertrophy and hyperfiltration. Then either hypoinsufficiency or second hit in the tuberous cells could predispose to premature apoptosis or maldifferentiation. So all these are potential causes explaining CKD in TSC patients. And what's the treatment for AML? There have been no controlled trials on embolization or surgery for AMLs, but we know that there is a high percentage of recurrence, 30 to 40%. And the risk of bleeding is there, and it increases when the diameter reaches 3 to 4 centimeters. Then reaching this point, complications may develop in as high as 70% of patients. Surgery and embolization nowadays should only be performed as emergency treatment in bleeding episodes. And treatment with mTOR inhibitors should be used as elective treatment before that happens, once the AML has reached 3 to 4 centimeters. This is one of the reasons that nephrology should be very aware of this treatment, because it's a change of paradigm. It used to be surgery or radiosurgery disease, and now it's moving more into a non-surgical disease. So what's the decision to treat acute bleeding? Of course, you need to be quick and do embolization if possible, if not partial nephrectomy, if not total nephrectomy. But what we recommend and what should be done is to treat asymptomatic AMLs. If are less than 3 centimeters in diameter, just follow up. And for those over 3 centimeters in diameter, post-treatment, which is mTOR inhibition. mTOR is the main molecule here, the main cause of the disease. And if we inhibit that molecule, then the cell growth and proliferation is stopped. These are some trials on sirolimus for TSC. They all work, all have positive results. I would like to highlight our trial with a very important decrease of AMLs in 1 year. But the main reason is because we measure the largest AML. And this is important, that the action, as in many different endpoints, is easier to see when the AML is higher or when the renal failure is higher. So it happens the same in any trial, but this is the explanation why it's easier to see in larger AMLs. Then the EXIST trial with everolimus was the trial that prompted the approval for from the agencies for everolimus in TSC. It was a double-blind, placebo-controlled trial with 10 milligrams of everolimus once daily in 118 patients, and they were during the first phase with placebo and everolimus, and then all had a very long extension with everolimus. You can see here the effect, which is very remarkable. They almost all decrease the size, the volume of AMLs. This is the highest decrease, 97%, and the smallest one, 3%. Interestingly, this decrease, this is the extension recently published. You can see how the maximum decrease is already achieved at between 1 and 2 years. From that point, you keep having the same volume, but you're not expecting the AMLs to disappear or to reduce further. It's just they reach a point where they stay stable, they do not bleed, and you must be happy with that. Even if you may see some small increases, but the main message is that no patient has bled on treatment. This is the time to progression of AMLs, and you see how well it works, that they do not progress, but the most important thing is that they don't bleed. They don't bleed. Regarding CKD, only those patients who already had chronic renal disease, they progress, but most of patients did not, and the effect of the drug on renal failure was not relevant. What about the dose and plasma levels? Because the trial they used 10 milligrams for everybody, and only decreased because of adverse events, and there were no modifications based on plasma levels. And we know changes a lot. We know that from transplantation and from these patients also, because some of them are under anti-epileptic drugs, which decreases a lot the levels. So the percent change rather than absolute change from baseline in angiomyolipomal lesion volume is correlated with everolimus plasma levels. This is a recent publication by the group, by Burt and collaborators. For we as nephrologists, we cannot use everolimus without plasma levels. I mean, it's something very hard to do when you are used to renal transplantation. So probably we should do plasma levels, and the suggested plasma levels are between 4 and 10. This is also an interesting work recently by Burt and collaborators, where these angiogenic biomarkers correlate very well with the treatment on everolimus in these patients compared to this dotted line on placebo. And also vascular endothelial growth factor D correlates very well with AML volume, both in treated and untreated patients. What about adverse events? Because this is a lifelong treatment. So we are concerned about adverse events. But the good news is that they are much worse at the beginning, and they get very well tolerated. This drug gets very well tolerated at long term. So they do pretty well on the drug. The most relevant adverse events are stomatitis, mucositis, mouth ulceration, which is quite common at the beginning. Then hypercholesterolemia and hypertriglyceridemia. Some of them need statins. Infections, which is very common in any disease, and this I mean in any person, and many of these are kids, so they have lots of infections, mostly not related to the drug. But hypophosphatemia is quite frequent, but not usually severe. Amenorrhea is yes, it's frequent, but these patients cannot get pregnant, so because of the drug, so well, it's not a big issue. And they have several hematologic abnormalities such as microcytosis, leukopenia, neutropenia, which are usually not severe and have no clinical relevance. What it concerns us quite a lot is proteinuria and microalbuminuria. This was not very well collected, I would say, in the EXIST trial, only with dipstick, but we know it's very important for a long life treatment. For example, in our trial that we checked the proteinuria, microalbuminuria, we can see how in most patients it increased, and in all those with a 5-year, they needed ACE inhibitors or ARBs. So it's something to bear in mind and to follow up in these patients. And also in one patient from the EXIST-2 trial and one from our trial developed nephrotic range proteinuria without having proteinuria at baseline. So this is an idiosyncratic response, but still something challenging, and that only, at least in our case, only stopped after stopping the treatment. So what the long-term effects of mTOR inhibitors in the kidney are still not well known. There's a polyester expression of nephrin, TRPC6, and NSK, and they are significantly decreased under long-term treatment with mTOR inhibitors. They also reduce polyester adhesion and motility, and long-term effects on proteinuria and kidney function are still unknown. Remember, this is a lifelong treatment. This may be if not a concern, at least something we must follow up and take care of. Then, with all this being said, will mTOR inhibitors target several renal abnormalities in TSC kidneys? We have some hyperinsufficiency, second hit, or will they worsen the progression of CKD? Hopefully not. On top of that, everolimus for the TSC manifestation has been granted approval by the European Medicines Agency for SIGA and for epilepsy. It works also for lung, facial angiofibromas, but there's not approval for these indications yet. Regarding surveillance and management for tuberous sclerosis, We mentioned acute hemorrhage should be treated with embolization, and asymptomatic growing angiomyolipoma over 3 centimeters should be treated with mTOR inhibition, and second-line selective embolization and kidney sparing resection. And to conclude, on future directions, mTOR inhibitors are the first choice for preemptive treatment of growing AMLs over 3 centimeters in diameter. The potential benefits of preventive therapy in reducing AML-related morbidities may outweigh the risks of long-term therapy. Future studies should address the impact of early detection and appropriate treatment of renal AMLs on preserving renal function. Plasma angiogenic biomarkers as measure of treatment efficacy should still be followed up, and further studies are needed. Also, we need further studies to address the impact of adverse events related to mTOR for this lifelong treatment that, on the other hand, spares kidneys and gives a better outcome for these TSC patients. And that's all. Thank you very much for your attention. And I would like to remind you of the next webinar that will take place on 29th June by Klaus Schmidt from Heidelberg, and the title will be Optimizing PD in Children. And that's all. Thank you very much for your attention.
Thank you very much, Rosa. This was great. I learned a lot from this as a pediatrician, and actually I have one question myself, but before I ask it, maybe I would like to ask anybody in the audience who has any questions to write these questions in the chat field so we can see them and we can answer them. So, Rosa, you showed nicely that the effect of the mTOR inhibitor was, there was a very marked effect on the VEGF-D levels. Is VEGF-D directly regulated by mTOR?
Well, I don't think so. I think that it's more about, well, I'm not an expert in this in cell molecular biology, but I think that it's mostly a biomarker. I mean, a surrogate marker of angiogenesis, which is definitely overexpressed in these patients, and it gets down with mTOR inhibition, which acts as an anti-angiogenic agent in a way.
Mm-hmm. All right. So then we have a question from Akila Hassan, who is asking, is 3 centimeters the cutoff for all ages, or would you consider treating if it's 2.5 centimeters in a younger child?
No, I think I wouldn't. No, the recommendation is over 3 centimeters, and it's because the accumulation or the chances of having microaneurysms there, or the chances of bleeding are higher, but I think I wouldn't treat a child with 2.5 definitely. I won't. Mm-hmm. Wouldn't.
Okay. There's another question just coming in from Jalila Mekali. Jalila, do you want to ask something?
I think she's mute.
Yeah, but she wrote, "Hi Rosa and Franz," but now, yeah, here it comes. So in the recommendation, it's also mentioned that aneurysmas are a criterion.
Yeah. Yeah, right. But, yeah, the thing is that with AMLs smaller than 3 centimeters, the chances of having an aneurysm larger than 0.5 centimeters is very, very low. I would say at the beginning of treating patients with mTOR, we were a little bit scared of treating patients with aneurysms without previous embolization, But as we get more used to use the drug and we see how effective it is, because if you check at 3 months, there's already a reduced volume. So we treat all patients.
Okay.
And we don't. It's true, Dalila, that we should check for aneurysms, but because in fact it doesn't change the approach. We treat them all with mTOR. Well, we don't do that often.
Yeah. Then there's an interesting question by Adrian Lungu. He's asking, if you have a child who had bleeding from AML and nephrectomy, so only one kidney left, would you consider everolimus even for smaller than 1 centimeter tumors in the remaining kidney?
From the evidence we have right now, I think I wouldn't. I will follow him up and wait till this AML increases. Yeah, I think this is the recommendation. It's not a prophylactic in terms of before the increase of AMLs, but once the AML has reached a certain size. So no, because they have adults in the same situation, and I'm not treating them also.
You're not treating them. Okay. Are there any other questions? Yes. Peter Hemmingson is asking, when screening these patients with MRI, we sometimes find other tumors. I have 2 patients with neuroendocrine tumors in the pancreas according to MRI. One of them has only been followed because of comorbidities, and it hasn't grown for 5 years. The patient is on everolimus. What would you say about the probability that these tumors are associated with the TSC?
Well, I think I believe that the strange tumors that appear everywhere in this disease can be related to this disease. There is a proliferative state in these individuals, and it's true. We see some unexpected tumors that they need to be related, because these people are too young and with too many tumors. I think it's such a strange chance. The chance is very small that they have 2 different diseases not related, and because of the proliferation state, I think they're related. But you mentioned the patient is on mTOR inhibitors. Mm-hmm. And well, mTOR inhibitors are anti-proliferative, and many tumors respond to this drug. And probably if any tumor in a TSC patient is related to mTOR upregulation, then these tumors will probably respond also to treatment. And because this is a lifelong treatment, we're not treating these people for 1 year, 2 years, 3 years, is lifelong treatment. So probably these tumors, for example, liver AMLs, which are quite frequent, they also respond to mTOR inhibitors, although there has not been any trial assessing that, but we know they respond. So probably these pancreatic lesions and whatever, for example, the facial angiofibromas is just spectacular, how they decrease and how they soften in color and shape, and they are less rough. So yeah, I agree that, sorry, it was a long answer.
No, but it's very interesting to share your experience. So there's another question by Chalila. She's asking, what is your opinion on the value of everolimus on sporadic or isolated AML? In Belgium, it's not included in our reimbursement criteria.
Yeah, same here. Mm-hmm. I would love to use it, really. And I would love to have a trial on that. Although this is really more a urologic issue, but I'm sure it will work. Mm-hmm. But it's difficult. You need to demonstrate that, you know. But I will be very happy. It's not reimbursed here neither, so I cannot tell you. But my impression is it will work. It will work.
Okay. All right, I think this seems to, oh, there's one more. Two more questions. Okay, so Adamu Sambo is asking, the mosaicism aspect you described is interesting. Would you recommend NGS to rule out PKD mutations even if array CGA has returned negative? I have such a patient with TSC.
So I missed the last part. So I recommend next generation sequencing for TSC patients in what situation?
If array CGH has come back negative.
If CGS has come back?
Yeah. If
negative, you mean?
CGH and it's negative, will you still do NGS?
Yeah, not probably in this case. In fact, the contiguous gene syndrome consists of a deletion, and next generation sequencing is not the best tool to identify a deletion. So if the suspicion of contiguous gene syndrome is high, I will do rather sequencing or other standard techniques, more easy techniques, not well easy. Old-fashioned, let's say, techniques to identify a deletion. MLPA, for example, will be much useful probably. I mean, I do not work in the lab, but I know a little bit about this, and I think MLPA will be more useful than next generation sequencing. Mm-hmm. But from my point of view, the diagnosis of contiguous gene syndrome shouldn't be too difficult, because you have a kid with tuberous sclerosis, with all the stigmata of tuberous sclerosis, and this enlarged cystic kidney. So yeah, I agree that if you have a genetic test, it's much better. But well, it's quite a typical presentation.
Okay. Right, I think this was so far the last question. So, and our time is actually up. So thank you very much again, Rosa, for this beautiful presentation and sharing all your knowledge with us in the Q&A session. And we'll be happy to communicate with all of you for the next webinar. Thanks a lot. Bye-bye.
Thanks. Bye.
Okay.